Hello, my name is Warren Hall, and I'm the National Manager of Support Services at the American Liver Foundation. I'd like to welcome you to today's installment of our Ask the Expert series. Today, our topic is palliative care. The ALF helpline and our social media platforms receive many questions about caring for a loved one when they come home from the hospital or when formal treatment may be ceased. And as we know, hospital stays these days are fairly limited. This can put a strain on the family or the caregiver for many reasons, and we'll touch upon some of those in our discussion today. The questions that we will be posing to today's guests were taken from those inquiries. If you have any additional questions, please pose them in the chat and we'll do our best to respond to them. Our experts today, and I did use the plural there because we have what those of us on the East Coast call a twofer, meaning a 2-for-1, but not just any 2-for-1. This is a husband and wife 2-for-1. And so we're really thrilled to have them with us today. Maura Burton is a board-certified adult-geriatric nurse practitioner and an advanced certified hospice and palliative care nurse. She is an instructor of medicine on the Palliative Care Consult Service at the University of Colorado Anschutz Medical Campus in Aurora, Colorado. Prior to her work in palliative medicine, Maura worked as a hepatology and liver transplant nurse in New York and in Colorado. When not at work, Maura enjoys live music, mountain air, skiing, and spending time with her husband and children. James Burton Jr. is a professor of medicine in the Division of Gastroenterology and Hepatology at the University of Colorado Anschutz Medical Campus in Aurora, Colorado. He serves as the section head of hepatology and the medical director of liver transplantation at the Colorado Center for Transplantation Care, Research, and Education. Dr. Burton is a board-certified transplant hepatologist with over 2 decades of experience in specialized care of patients with acute and chronic liver disease before and after transplantation. Now, it doesn't say this here, but I'm adding it. He enjoys live music, mountain air, skiing, and spending time with his wife and his children. So I want to thank you both for being here with us today.
Thank you. It's nice to be here.
Thank you.
Great. Okay, so we'll jump right into our questions that we've received here. First, can you just tell us generally what is palliative care? We hear about it, or maybe some people haven't heard about it. So what is palliative care?
Sure, I'll field that one. It's a question I get every day. Mm-hmm. It's actually a medical specialty, and we focus on extra support for patients and families that are dealing with serious illness. So think of a specialty like cardiology or hepatology. Palliative care is just another medical specialty. We have extra training in supporting patients and families with serious illness. And the different thing, well, there are a lot of different things about palliative care, but one of them is we come as a team always. So there's a provider like a nurse practitioner or a physician or a PA. And then there's also our entire interdisciplinary team. So that's like a chaplain, a social worker, or other therapists. And again, we're all trained to deal with serious illness. We really try to get to know patients and understand what's important to them as people. So we call that goals of care, which really means what's important to you, what do you value in life? But we also help with symptoms. So that's like if you're having pain or nausea or whatever it is that illness is causing you physically, we help treating those things. And we also look at the person as a whole. So we talk about social, emotional, spiritual aspects of how a serious illness might be affecting somebody. We're also very good at interpreting complex medical things. So you go to the doctor's office and you hear Dr. Burton talking about all these fancy words and things, and we can help kind of translate that into ways that you can understand. And finally, we help kind of write those things down in something called advanced care planning. And I can talk about that a little bit more in detail later on, but it's really getting down on paper what's important to you and what you would want in a situation where you could not speak for yourself.
Okay, so now most people have heard of hospice care, and I think sometimes they confuse it with palliative care. Can you just say a word about those the differences there?
Absolutely. Yeah. Again, a question we get all the time. So the big difference is that palliative care can be provided at any point during a serious illness. Hospice care, on the other hand, is care, end of life care. So care that's provided to a person who has a prognosis of 6 months or less. So that's how they're very different from each other.
Okay, so we're not talking about, you know, kind of nearing the final stages. We're talking about much more prior to that.
Symptom management associated with one's disease, like a chronic disease.
Okay. And so when would somebody then consider this? Now, in my introduction, I had said when somebody comes home for the hospital. Now, is that accurate? When does palliative care, or when can palliative care begin? When should a family member caregiver consider this?
Well, in an ideal world, it would be at the time of diagnosis of a chronic illness or a serious illness, but that's just not available, and that's not where we are right now in terms of providing palliative care. I'd like to focus specifically on liver disease, and I'll have Dr. Burton here talk about the specific kind of triggers we think about when we should consider palliative care in these patients.
Yeah, I think for with liver disease, we're talking specifically about patients with cirrhosis. Now, just because someone has cirrhosis doesn't mean you're going to die, and there's lots of people who have cirrhosis where liver's functioning very well. I think we're specifically talking about what is termed decompensated cirrhosis, or cirrhosis with problems. And these problems would include like ascites or fluid in the abdomen, bleeding varices, these dilated veins in the esophagus that can bleed, hepatic encephalopathy, which is liver confusion, severe jaundice, kidney failure. All of these complications of cirrhosis, I would term a decompensating event, from when someone goes from cirrhosis with no problems to cirrhosis with problems. And when you develop these problems, the risk of death does increase. There are other prognostic markers one can consider with looking at cirrhosis. You know, the MELD score, or the Model of End-Stage Liver Disease score, is used to rank people on the transplant list. It's a score that goes from 6 to 8 being normal and 40 being the highest. The higher that score goes, the higher your risk of death. So certainly you could say anyone with decompensated liver disease or a MELD score maybe over 15 should consider that their risk of death is probably, high enough to consider palliative care. Another thing one might consider is if your liver disease is sick enough to warrant a liver transplant, that's probably sick enough to consider involving palliative care.
Okay. What is, sometimes we hear curative care. What is the difference, or is there a difference, curative care versus palliative care?
Good question. Palliative care can be provided concurrently or alongside with curative care. So an example of that might be somebody who has cancer is interested in curative care. They're interested in getting therapies to cure the cancer. Palliative care can come right alongside that and help support people through that process. It doesn't take away anything. It only adds to any sort of care you're getting.
Great. Okay. How does somebody begin? So when you said at time of diagnosis, you can even begin the thought about palliative care. How do you begin? Do you ask your doctor? Do you check with the facility? Do you ask your insurance company? How does the process begin?
Yeah. The best way to get a referral to palliative care would be to talk with your primary care provider. They would know in the area who provides palliative care and who to refer you to. If they don't know, there is a website called getpalliativecare.org, and you just type in your zip code and it gives you a list of palliative care resources around you. And that reminds me too, to explain that there are different settings of palliative care. You can have palliative care in a clinic, like you would go to see your hepatologist in clinic, you could see palliative care. Palliative care services can come to your home, which a lot of patients and families really like, especially when you're dealing with an illness. And then finally, there's also palliative care when you're in the hospital. Not everywhere has all these resources. I want to highlight that because there's a lot of places still that don't have palliative care or don't have a big robust service to help. But yeah, ask your primary care doctor. And if you're in the hospital, you ask your doctors or your nurses in the hospital, say, hey, do you guys have a palliative care team here? I'd really like to explore that. Just talk to them and see how they might be able to help me. Yeah.
I think too, you know, one of the probably the more common ones we get is for at home, because especially with something like liver disease, people often will call us and say they're not doing anything. Or, you know, they sent my husband home from the hospital and I don't know what to do. And so I think it's that in-home care that a lot of people are looking for or hoping for, because especially if HE is present, you know, the hepatic encephalopathy, because now we're dealing with some cognitive issues that can be overwhelming for a loved one or a spouse who's at home. So let's use that as an example. So if somebody is at home, what could they, because I know it's all going to be different, what could they expect from palliative care in the home? Like who would come to see them? What would be done? You know, what would be some of those particulars?
Yeah, great question. And you highlighted too that it might be different in different places, but it's definitely different locations, but also different agencies kind of work differently. But generally, a nurse practitioner or a physician will visit the home maybe once a month, maybe less, maybe a little bit more, depending on what's going on. And then between those visits, you might see a social worker or a chaplain or a therapist, like we've got music therapy and art therapy, those sorts of things, to come and see what support is actually needed in the home. Is it physical symptoms? Is it the encephalopathy? Is it pain? Or is it more existential distress? Or, you know, worrying about death and dying, things like that. So depending on what the issues are at home, palliative care will kind of think of, okay, which person or which domain of a support service would make most sense to go to your home and talk to you, and actually help talk with the liver team or the primary care team if there's confusion or if you feel like things really aren't moving along. That's also where we can help with the communication.
Wow, you know what I love about that, the holistic element of this, you know, because we're dealing with not only the medical, certainly, but then we're dealing with the, you know, if you want to say the psychological, the spiritual, which often gets left out, I think, in some cases or in some facilities. And, you know, so to have all of these things, and I love you mentioned the art therapy kind of thing, you know, probably something that you wouldn't really think about when we're talking about care for someone. And so this is really wonderful in that it does touch upon many of the things that, you know, you might not even see in that hospital clinical setting. So, so what would be some of the medical things? So let's say somebody does have the ascites, and we know that's building up, that has to be drained. Is that something that a palliative care team can do at the home? Can blood work be done at the home? Are these some of the types of things that a palliative care team can do so that the person, let's say, doesn't have to go out to go to a hospital, to go to a clinic? Are these types of things involved as well?
Well, I think with ascites, I don't think you're going to get a paracentesis at home by a palliative care team. But I think if you do have ascites and it is something that is a problem for you and your goal is to stay home and not keep going back to the hospital, that is something that I would consider, if you're, you know, more palliative approach and comfort, or even on hospice, I would consider, instead of going get it drained every week, you could have a catheter placed in the abdomen and drain it at home. You know, if you're doing blood draw, palliative care is not like home health or home care providers. I mean, someone would have, they probably wouldn't be drawing blood but I think they could, my belief is they can go to the home and actually assess what does the home look like? I mean, what is the environment like? What might be some of the needs this person might have? And I think it may be more comfortable probably talking to someone about death and dying at your own home rather than sitting in a hospital bed naked in a little flimsy gown, you know. So I think that probably is the role palliative care might have going home and assessing what might help with the quality of life for this patient, and then helping relay that back to the providers that are giving the actual medical management.
Right, because there's been cases where we've seen patients who are, you know, coming in and out of the hospital every week for whatever procedure, a paracentesis or what have you. And palliative care is a good kind of a different viewpoint to kind of step back and think, what are we doing? Are we actually reaching this person's goals? And if we're not, thinking outside the box, you know, should we put a drain in this person? Kind of asking those questions, and then going back to the medical team and saying, hey, what's possible other than what we're doing? Because, you know, this person really wants to be able to spend their time at home, watch their grandkids grow up, things like that, rather than, you know, spending that time in the hospital.
Yeah, and hence the difference between hospice and palliative care is that this is kind of ongoing. But along with that, so when we're talking about people who have advanced liver disease, the hope or perhaps the thought is that this person is also on a transplant list or looking to be on a transplant list. Now, would these two things work together? Does having palliative care exclude you from a transplant list or not? Can they work together?
Well, I think that is it is perceived, I believe, that one cannot have palliative care and be considered for a liver transplant. And I would really disagree with that, because palliative care is not, it's only helping with, you know, communication about what your goals of care are, maybe helping your quality of life. And there's no reason why those goals can't be run concurrently with getting a liver transplant. I mean, here at the University of Colorado, we've actually incorporated palliative care into our inpatient liver transplant evaluations. A little bit of influence, perhaps, being the medical director and my wife being in palliative care. But for any patient who is so sick that they have to be evaluated for a liver transplant as an inpatient, we get an automatic palliative care consult. And those providers see the patient and participate in our selection committee in sharing what the patient's goals are and what they need. And I find it to be very helpful in taking care of that patient. You know, half of patients at our hospital who are evaluated for liver transplant as an inpatient are not candidates for liver transplants for a variety of reasons. And since we implemented this, we saw not only shorter hospital stays and that patients knew what they wanted already, we didn't have to go back and start over from the beginning, but they also were able to have their goals assessed better. And, you know, more patients were sent home on hospice immediately from the hospital than maybe went home without hospice and ended up seeing someone outside the hospital. Additionally, we've involved palliative care in any patient who's on the transplant list who's in the ICU awaiting a liver transplant. And that's because if you're so sick that you're in an ICU, you're likely to still be in an ICU after a liver transplant, and you're likely to remain there for a good week or so. And so I think we realize it's important to have that additional support for the family as well as the patient in communicating to the transplant team, you know, how patients are doing, how their families are doing, and to have another level of communicating, you know, providers involved, especially if there's confusion or anything else of what's going on. So I do believe it is something that can happen concurrently, though. Now, on the other hand, you can't be on hospice and be a liver transplant simultaneously, because hospice, you're kind of taking care away, you're kind of providing only comfort. Well, taking care away.
The focus of the care in hospice is comfort and quality at the end of life.
Yeah.
And that does not, in our minds, that is not congruent with working towards a liver transplant.
Yeah, no, I would agree. But you can certainly involve palliative care.
Yeah, and so by looking into or actually getting palliative care, the patient's not giving anything up in terms of their care. So there shouldn't be a concern that, well, gee, if I opt into the palliative care, that means, 1, 2, 3 is not going to happen. And that's,
you hit the nail on the head, Warren. You hit the nail on the head. Doesn't take anything away. And I think, unfortunately, it's still a common misperception amongst providers, not just patients and families, but a lot of medical providers. So now you all have that knowledge to educate other people as well, that palliative care is not taking away anything, it's only adding.
Yeah, and I think that's a big concern. So now a practical question. Do you know, let's say in terms of coverage for this, in terms of insurance stuff, because these days, everybody has to look into everything to make sure it's covered because of cost. To your knowledge, is palliative care, or is that going to depend on the insurance they have, et cetera? But in terms of covering the cost of this, in your experience, does insurance cover it?
In my experience, I've never had a problem with palliative care being covered. It's viewed as any other medical specialty, like you have to go to a cardiologist or a hepatologist. It's a medical specialty. So again, yes, Warren, you would have to check with the individual insurance. I can't speak for everybody, but I've not run into a problem with it.
Right. And maybe finally, in terms of because as we began saying that a lot of people have not heard the term palliative care, let alone, which is obviously why we're doing this here, to get that information out. Is it increasing? And I know that you're in Colorado, so, and in your facility, as you've indicated, this is so prevalent. Do you see this as something that is widening, that's happening more in facilities around the country? Is it something that physicians and facility or boards of facilities are saying, hey, this is a beneficial service, and if we don't have it, we need to look into it? Is this what you see happening?
Oh, absolutely. Yes, at our hospital, it's grown. It's just blown up in the amount of services and how many providers we have on our team. But I can tell you across the country, across the world, palliative care is a medical specialty that is growing and growing. There's more educational opportunities for advancing your degree. Like I have a certificate in palliative care that I went to school beyond just the nurse practitioner school for, and there are fellowships that are growing as well across the country. So yes, this is a field that's growing and growing, and I wouldn't be surprised if someday we are embedded in transplant systems across the country.
Oh yeah, I would love to incorporate palliative care into everyone undergoing a liver transplant evaluation as an outpatient. I mean, that's a goal I have, and one I hope we will achieve. I would say this is something that even liver societies like the American Association for the Study of Liver Disease, they only just recently came out with a kind of a consensus document on incorporating palliative care into people with chronic liver disease, and that just came out in February. So, there are other societies, with cardiology and pulmonary medicine that have had, guidelines of when you should initiate palliative care. But the liver societies, I think, are a little bit behind in this, but they are catching up.
In my experience, palliative care has really started growing in the oncology world, but I think other chronic illnesses are really catching on to the benefits of having palliative care involved earlier in disease states.
We know the AASLD has their conference in the fall. Let's hope that maybe 1 or 2 of the sessions on there could be about palliative care.
Absolutely. They could have a breakout session just on palliative care and liver disease.
Yeah, because that, as we said, if this is a growing thing, we need to be really on board with this. So, so any closing thoughts? Anything important you feel for our viewers or for people? I know we touched on really a lot of good stuff here. Any other thoughts or just suggestions for the folks who may be watching this because they're in a position themselves or for a loved one to need something like this?
I would say a lot of times in liver disease, patients' family members feel alone. for a lot of reasons, but one of them is because of the way that the disease affects the brain with hepatic encephalopathy. And I would just say that if you can try to get palliative care involved in your loved one's care, I hope that would make you feel less alone and give you ways to feel supported throughout this, whether it's, emotional, spiritual, or helping with physical symptoms. But my hope is that makes you feel a little bit less alone, knowing that that's a common feeling as well.
Right.
Yeah, I would just add that, liver disease is typically a progressive disease that, ultimately does have a declining health status. And while, I think involving palliative care early, getting to know a provider, over time will be helpful, because if you are on a trajectory where transplant's not an option and, death is an ultimate outcome of cirrhosis, I think having someone involved early, and it also helps make that transition to hospice, I think, a little bit easier as well. And I think, having chronic liver disease, I think getting palliative care involvement in that transition to hospice is probably bigger for the family and the loved ones of the patient, rather than the patient who needs it in some situations. Because with liver failure, usually, at the end of life, people go into a coma and just go to sleep. But it might be harder for the family to have to worry about their loved one and maybe have the fear that they might be in pain or suffering. And I think palliative care providers can provide that reassurance and support for them.
Wow, that's such a great way for us to end today, because, unfortunately, folks contact us quite a bit about asking, is there a support group for liver disease in my area? Or, are there any support groups? And sadly, there's not a lot. There are not a lot. And, add the stigma of liver disease, whether for yourself or a loved one on top of that, and more of that emotional support that palliative care can offer in that holistic approach can really help with that as well. So I really think that that's, probably one of the less spoken about aspects of the palliative care, because we are focusing on the patient, but really the benefit for the family. I hope that's a takeaway that people who are listening to us today will be able to take from this and to realize that the help is there for them as well. Great. Well, that's all the time that we have for today. So Maura and Jim, on behalf of all of us at ALF, those who are live with us today, and those who will be viewing the recording of this program, because we are recording it, and it will be found on our YouTube channel. I want to say thanks so much for your time today. We know that your time with us is your time away from your children, but we certainly are most grateful for your being with us. For additional information about today's topic, as well as other information about liver health in general, please visit liverfoundation.org. That's our website. You can also contact our national helpline. You can join our Facebook groups, or you can see some other disease-oriented and wellness-oriented information on our website. So thank you all for joining us today, and we'll see you again at a future episode of our Ask the Expert series.